Have you guys ever done a Kahoot or a live quiz before? Okay, this is it. So if you can scan a barcode, if not, this is how you can get in. Once you're in, your name will show up here. So if you're not familiar with these, it's a live interactive question bank. Okay, so there is going to be a winner at the end of this. You get points for getting a correct answer, and you also get points for doing it quickly. So if multiple people get the right answer, it's whoever did it fastest will get the most points. Some of this is medicine related. Obviously, some of this has to be random trivia with sports. So if you know nothing about medicine, you have a chance. If you know nothing about sports, you still have a chance. And then all of this will be done on your own personal device, so you don't need to be watching up here. This is just to see the leaderboard and things like that. All the questions and answers will be on your own phone. We got 29. That's a pretty good number. You can join in as we go as well if you'd like. We'll get started because we got a little bit to get to. Okay, we'll start off with an easy question.
She put what she likes. She's like, I know it's not it, but
55% got that. That's pretty good. Good.
Supposed to read these, or are we just guessing?
There was an article that went out that'll have some of these in it.
I'm just
I know.
trying to get there.
Yep. Yep. HDH. Who is it? Who's on top? Ah. All right. This one was pretty split. New leader. So disappointed. Doesn't exist anymore. Yeah. All right, we got a few sports fans. That's good. Oh, good. Oh, that was really split. Okay, the last two are really opinion questions. I don't know that there's a little bit of an experiment actually for these last two questions. So these are free text. This is meant to be a real answer from your own experience. So I listed a few of the most common responses that I got. So it tagged if you mentioned one of those keywords. This is a similar format. Okay, that one was a little bit tricky. You had to match exact keywords. But at least get you thinking. That's what we're going to talk about today. Here's our final. Steve-O. Round of applause. Congratulations. Yeah, there you go. Okay. So, I had an experience. I had a lot of experiences that are all very similar, but recently had a patient. We get to go see all the patients just before we wheel them back to the operating room. One last touch point to review history and physical exam and make sure that everybody agrees on the surgical procedure, what the symptoms are we're treating, and things like that. So this is minutes before they're going back under anesthesia, and we get to review and answer any questions. And had a patient that was undergoing a pretty straightforward procedure, one that we do very commonly, and I asked if he had any questions, and then he went off to sputter out almost a dozen questions of what were the very basics of what that surgery entailed and what to expect in recovery. Things that I know would have been covered at least 3 or 4 times before that point, but they were all new questions for him again. And I happened to have a student with me at that time, that's why he stood out to me, because I had to turn and say, I promise we do a good job in the clinic. I promise we teach these things. Okay, and then it's been such a common experience that the patients need to hear this several times and from several different sources to really make it settle in. So it's had me thinking about how do we approach and how do we communicate, what's the vocabulary and what are the things that we're using to teach and speak with our postoperative patients, because it's a very similar experience. So we'll run through a patient case. This was a recent patient of ours, 43-year-old female. She was 2 months, status post a discectomy. Had recurrent pathology seen on an MRI and came along with that recurrent, very similar symptoms. Tried to undergo conservative management in that couple-month time frame after surgery, but eventually was recommended to follow through with fusion at the 5-1 segment and came back to the OR. Has anybody seen this type of patient before in your offices? Okay, so we're all familiar with this scenario. This is kind of the idea that we're going to run with, okay? Real quickly, so surgery that's recommended is the MIS TLIF, which is minimally invasive transforaminal lumbar interbody fusion, very common. This was just quickly from the article that went out where we got some of this. Some of the common concerns or some information about that surgery. Subsidence and cage migration. We're talking single-digit percentages of how often this is happening. Okay, and I could maybe count on one finger how many times I've personally seen it through our office. It's just not very common. Okay, those that do have complications typically have comorbidities, and then a short little blurb about MIS versus open. This I thought was interesting. I wanted to look at what are the most common complications that come from lumbar fusion. Another interesting experience, and maybe this is just me and my marriage, maybe you guys can relate, but my wife had to undergo a procedure fairly recently and went under general anesthesia, and then afterwards was told by the office a few of the concerns to be watching out for, a few red flag symptoms that she then was given the office phone number to call if she had some concerns, and sure enough, had some concerns. Felt like she was having some of the symptoms they were describing, so I tried to reassure her that I had some experience in this world and gave some reassurance that it was likely not as big of a deal as she thought it would be, but she decided to not take my word for it and called the office phone number on a Saturday afternoon, and I know what it's like to be on the other side of that phone call. And they told her, they did a good job, gave some good reassurance, but then also validated her concerns, but ultimately it was not a big deal. But she comes back to me and says, hey, turns out that they think it's going to be okay. And I said, I know, I told you that. But it's funny being on the patient side of that because they need to hear it from a trusted source. But we also, as the trusted source, okay, I'm not that, they need to hear it from their healthcare providers, which is everybody in this room, okay? And it's nice to be familiar with what are the most common things that the literature is showing is going to be these complications. So anything surprise you on this list? Yeah. I was surprised at that as well. Yeah.
The screw valve position surprised me as a common major complication. Doesn't happen here.
Uh-huh.
It shouldn't happen anymore.
It really shouldn't, yeah. The thing that stood out to me about the major complications, that's the big things that really concern us that potentially harm the patient. Those are straightforward things. You're going to know if those are a problem. We take imaging scans before we close up the patient and send them on their way. We would know immediately if there was an issue with the positioning of the screws, yeah. It's true. Yep, there's a risk involved with all of this. Okay. Are the stuff that we see every day in our clinics and the way that we interact with the patients, are those concerns on this list? Does somebody come into your office complaining of anemia after surgery? Okay, not commonly. Okay, because it's not, a lot of the things are not on these lists of the major or even the minor complications that we see after surgery. They're valid concerns from the patient, but typically are not something that indicate a major problem. Okay, so our patient gets into surgery day, gets wheeled back into the operating room with Dr. Edwards. Okay, has a successful, uncomplicated surgery. Everything goes well. Back to PACU. Mission orders, they're staying overnight. Post-op day 1, this is just a quick snapshot of our labs that we see. Anybody concerned about the labs? Spoiler alert, it's not concerning. Okay, just a few things that we commonly see, a few of the immediate issues that we hear from our post-operative patients. Okay. The obvious question the patients are asking is, what can I do? Okay, does anybody know what this is? BLT, bacon, lettuce, tomato. Okay, also commonly in our world stands for bend, lift, and twist. Everybody knew that, okay? Should patients bend, lift, and twist after surgery? Absolutely, okay? This little acronym, I hope, goes away at some point, okay, because it's just not helpful. Okay, this is kind of the bulk of what I wanted to get to, is really practice what we preach and collaborate. Wanted to hear the discussion from those that are seeing all of our post-operative patients, and in general, how can we learn from each other. So I've been, the last week or so, been bugging a few people to ask what they see when they're treating our patients. So this was our nurses and anesthesia providers, kind of the immediate post-operative stage, and a few of the common concerns that they hear from our patients. Okay, what position can they commonly be in? A little fun with that, because I'm actually not sure exactly what word goes there. But they say, I still have numbness in my leg, so I guess surgery didn't work. Okay, and then they will say, well, I had right-sided symptoms before, but now I'm feeling things on my left side. Okay, and can I go up and down stairs once I get home? Do we have anybody that sees our immediate? We have a few Dry Creek people. You guys do all of our immediate post-operative care. Yep. I saw Steve. Okay, yep. So how does this match up with what you're seeing immediately the first day or two after surgery?
Close.
What's that?
Pretty close.
Pretty close to what your experience was? Anyone else? Ben, what do you got from our Dry Creek folks? What's the common concerns for day 1?
I think the biggest concern is when the neuro symptoms, if they aren't resolved. I think some people still want to have that immediate relief, but there's concerns about what they can do. I know that you guys are educated, but they still have those. Can I shower? Can I sit in the chair? Am I okay to sleep on my side? Those basic questions.
How do you address that with them?
Depends on the surgery. Depends on what they did. I work through everything with them. Through activity, I think, is the biggest thing. So yes, you can move. Yes, you can do this, and work through those things. And provide the tools that will allow them to feel comfortable doing those.
Yeah.
I like to go through a timeline with them, kind kind of, this is where you are on day one, and kind of help them realize, the nerves. I always tell them that the nerves are really finicky. They're a little bit inflamed. They're kind of angry, and so they're just going to have to work themselves out. And as we do these exercises and go through this timeline, I also give them kind of a little bit of a, you need to look at your progress on a week-to-week basis. I always remind them, where were you last week compared to where you are today, and where are you going to be in a week compared to where you are today. And so that kind of helps them give just a little bit of a perspective.
Yeah.
I think the perspective in their situation is huge, because after they've had surgery, they lose a lot of independence, right? They're not necessarily in control of everything that's going on as they were prior to surgery.
Mm-hmm.
And so, their bowels don't work the way that they used to, and they have this numbness, tingling, and pain is huge. And so giving them that perspective, giving them a timeline, and then setting goals with them, I think is super important.
Good, yeah, I really like that. Perspective, I think, is a big thing that you mentioned. It's an unknown experience for these people, so even something that is probably not concerning is new or different to them, and they don't have the tools and the strategies to navigate that, so it's helpful to try and give perspective. Okay, so we get out of day one, they get discharged back home. Okay, this is our awesome staff in the back room answering messages. Okay, so now the first few days, these are the common phone calls that we get, okay, now that they've been home for a little while. Okay, and if it sounds redundant, it probably is. It's a lot of the same concerns. Okay, what am I allowed to do? Okay, commonly they will say, I've been really good about not bending, lifting, and twisting. When can I start doing that? Okay, we're still getting that message. Okay, very commonly they say, well, my leg still hurts, or my back is really sore. I've been out walking like you told me to, but now it hurts a little bit more. And then also commonly, when should I start being involved with physical therapy? Okay, any thoughts on this list? Is this common for you guys as well? Trying to break down the silos and see if everybody's having a similar experience. Yeah, go ahead.
I think it's hard because my neighbor had a surgery, they'll say, or my cousin or whatever, and who knows what they had. Maybe they had a discectomy, and they're always comparing. They're always trying to find, reference points. And I think a lot of times as therapists, we spend a lot of time, educating and focusing again on where they're at, what they can do, and what their goals are at this stage.
Mm-hmm. Yeah, that's a big one. I hear that all the time. Well, my neighbor did this, and they had a totally different experience, so I'm just frustrated. Yeah.
One interesting scenario was there was a spine surgeon in Boise that came here for a anterior posterior L5S1 fusion. And so he worked at Texas Back, and he's been in Boise, he's been practicing a long time. And he's had hundreds and thousands of patients go through surgery. And then when he went through it, he had all these concerns. And he was talking to his wife through the process, and she was like, if you had one of your patients call in with these concerns, what would you tell them? And it was interesting to hear his perspective going through it as a patient when he had seen all of his patients have it. And we met up with them up at the ski resort a couple weeks ago, and he's a ways out from surgery, maybe 2 or 3 years maybe, and he's great. But that first few weeks can create a fair amount of anxiety because they really want it to work, and even somebody that has a lot of experience with it and knows the answers may still have these questions and just needs a little reassurance.
Yeah, I like it. That's really good. Yeah, go ahead.
I think it takes a lot of people to get on board. I mean, this discussion, right, to get rid of these old ideals.
Mm-hmm.
And I worked at St. Mark's just 3 years ago, post-op, spine, getting people out of bed, and protocols were no bending, lifting, twisting.
Mm-hmm.
Log rolling, and we taught all of those things, and that was just a few years ago, right?
Mm-hmm. And
I'm sure they're still probably doing a lot of that today. And I think a lot of the hospitals are still preaching the same story, and a lot of it is because the predecessors taught it. And it's adopting the ideals and clinical practice guidelines and really talking about it again and again and again.
Yeah, Yeah.
Society takes a long time to catch up to what we're talking about, and we're just barely having this distinction.
Yeah.
You know?
That's perfect. Yes, I appreciate that. Yeah, it is. It's a unique experience when you're the patient, and that was the experience I had at home. And then it is. It's commonplace to do what you've seen done beforehand. And then the last group is most of you in here. Okay, this is now maybe months out of surgery. Okay, and these are the common concerns that I had. I capitalized a few of them that were very, very common answers that I was asking people. Okay, fear avoidance, what does that mean? And how would you explain that when you see that?
You know, fear avoidance is, there's a whole survey for that, but it has a lot to do with, and some of the first questions are like, if I move, lift, or do this activity, can I make my pain worse, or can I make my back worse? And these patients clearly have decided to enter into the surgical realm, which means they generally had pain for usually a little while, and you know, our fault is we've told them that Dr. Edwards is amazing and he's going to solve all of their problems and that their world is going to just be perfect after surgery. And so when they hear that, and then they come out and they're like, I still have pain, and they're nervous, and they're also a little bit afraid that if they bend, lift, or twist, right, because their neighbor just told them the same thing in church, right? So it's, you know, back to the point is we teach this in the hospital, but we're teaching this in our community as well. People say, oh, you're not supposed to be bending, lifting, and twisting. Let me get that for you. They're just afraid, right? And they're afraid to move, and they need that confidence from the outpatient side. They need that confidence that they can do things within, you know, smart movement, right?
Yeah.
Work, you know, I forget what Ben called it too. It's on the top of my head, but you know, we need to teach them that they can move, and we'll still see that. If you see somebody who's in my practice, we see somebody who's afraid to move, I'll just look at them like, you're afraid that when you bend, like pins, plates, and screws are going to come flying out. And they just laugh. They go, oh, well, maybe not that. I'm like, so you did sort of think that on the inside, right? And that's fine. They don't want to wreck it. Like they don't know what they can do. That's really where this education part is so important. Like, look, that's fixed, that's strong, that's in bone. Like, that's not going anywhere. As long as you don't catch a 50-pound weight drop from 100 feet in the air, like things are going to be great. So the fear avoidance is just huge, but we have to give them just the confidence that they can do things, and we just have to build on small movements, build on small actions, build on small activities, so that they can keep doing this.
Good. Yep. That's perfect. I had asked Scott here a couple weeks ago the same question, and I said, what would you do if a patient comes to you 6 weeks out of surgery and they say, I'm told I'm not supposed to bend, lift, and twist. What are we going to do in therapy? And his answer was, well, we're probably going to bend, lift, and twist, which was great, because it's to that point exactly. Is we want to get them past the fear of movement. And then another interesting point that came up was the idea that can build on itself too, because when they are stiff and they've been locked up and rigid for several weeks, and then they move and it's a little bit painful, now their movement kind of reassured their original fear that movement was painful, and so they don't want to do that even more so. How are we breaking that down? How are you guys dealing with that idea?
In the clinic, when the patients come back for their post-op appointment, I like to educate them, as you do more, you're going to do a little bit of this. So a little bit of pain as you're doing more activity is normal. If it's so much pain that you're out of commission the next day, you've probably done too much. So I think just educating them kind of that they should move and that pain can be normal, but that let pain be their guide and kind of follow that from there.
Perfect. Okay, yeah, go ahead.
This is definitely our expertise as PTs.
Yeah.
Our job is to get them moving and break down the movements that are digestible, and they can just work through different series of progression to be able to develop confidence in themselves, right? So we start with little spine movements and seated, and then we can work on, a progression of back to full activity. But if they want to be able to garden, right, they got to be able to get down to the ground. How do we break down that movement in segments so that way they're confident to be able to get to the ground?
Great.
That's part of our job.
Yeah, good. That's great. Yeah, I appreciate the feedback. Okay, great conversation. So hopefully we can find a way to collaborate here and make sure that we're giving this consistent message. Kind of the three key takeaways I had here. Snap through these real quick. This is kind of what I took away from this, is the goals of what I would like to accomplish with this type of discussion and conversation amongst everybody, and taking advantage of all the great experience that's in the room, is when we're having these conversations and interactions with the patients, how can we normalize this for them to know that this is new for you, but the thousands of other people that have done this have also had a very similar experience, okay? And then give them the trajectory of what that will likely look like, which Steve was talking about. Okay, try and de-escalate some of the concerns and the anxiety, which was great. That was kind of the experience with my wife on the phone. A lot of anxiety, but the provider on the phone really was able to de-escalate that and help her feel confident. Didn't do anything, but she felt better about it, right? And then hopefully us as a group here, that we're all treating the same patients, that we're giving a consistent message, that they hear it from multiple sources, and then they have the confidence to know that that really is in their best interest. Okay, and I think we're spent out of time, so thanks.